in OCT and visual field. So I have no financial interest in either of the instruments. So perimetry, as you know, is a highly subjective test. For accurate results, you need to depend both on the patient and the perimetrist. So artifacts include wrong refractive error, wrong birth date, small myotic pupil, cloverleaf field, white scotoma, low-hanging blind spot, and rim bar artifacts. So if you look at that, that's a refractive scotoma. Up-to-date refractive data needs to be put in. Correct trial lenses should be put in. Spherical correction should be placed closest to the patient's eye. Cylindrical lenses to be oriented in the angle of astigmatism. Thus the clover leaf, as you see the signature clover leaf out there, and it's a characteristic of a fatigued field with a high false negative. This is a white scotoma, the bits of white scotoma that you see around out here. So in the grayscale, multiple white areas, so-called white scotomas, thresholds are seen in the periphery are not physiological, and white scotomas draw the attention to a high false positive response of the patient. Here's a low-hanging blind spot. So that's related to poor fixation. Numerous fixation losses indicate poor fixation and therefore poor reliability of the test. And the patient's head also might be tilted, so you need to take care of that. Rim bar activate, that's when the trial lens is not close to the eye and the periphery of the trial lens actually comes in the way of the patient's visual field. That's when you get this kind of a rim bar activate, as you see out there. Ptosis, when you have ptosis in a patient, you need to be careful. Otherwise, see, the first field we did was this, and then we tapped up the upper lid, and this is what we got, the field. So very different. That's the pattern deviation that I'm pointing at, which we look at in glaucoma. So pseudophakic PCO, in that you might get something like this, a paracentral scotoma. And macular grid laser, you need to be aware of what's there in the posterior segment, or you might get something like this, which resembles an double arcuate scotoma. So advanced field loss, we actually don't pay any importance to the gray scale when we're looking at glaucomatous fields, but here when you have something like this, then you actually need to see what's going on. So this is ISUT progression analysis. I got this because I just wanted to point out that here actually there's a structure function correlation that the octopus has in its ISUT, and here these green lines are the ones which are fine, otherwise these are the areas which have actually progressed. So the octopus could be a reliable apparatus to use for detecting progression in a patient. So points to remember are successful communication between perimetrist and patient are of utmost importance. The patient needs to be comfortably and properly positioned. Activate the forehead rest alarm. Then you have the comments by the operator on patient performance and accompanying circumstances are useful for interpretation. Always have a word with the perimetrist. Potential operator errors are listed in the field analyzer, and please insist that your perimetrist actually goes through them from time to time. The grayscale is of limited use, but distinctive patterns such as the clover leaf suggest that the test data is not reliable. The four-wheel threshold measurement option should be switched on. Use of diamond fixation targets can help obtain reliable fields in patients with central visual field defects. Baseline fields should be established as soon as possible. This is very, very important in glaucoma diagnosis. You need to establish a baseline field, and that's going to be your parameter when you follow on the patient in future. And always consider the complete clinical picture, including the role of coexisting conditions. Never interpret the visual fields in isolation. Clinical relevance is always important. I'm sorry, this has actually gone back. So anyway, the factors affecting, that was a screen which I wanted to show you from Dr. Joel Schoeman, one of the makers of the OCT. Can I go back on this screen? In which he actually said that ganglion cell complex focal loss volume was the best predictor for visual field conversion, and 82% of the visual field conversion preceded an abnormal OCT. But having said that, I would say you need to be very careful when you're interpreting the OCT, and the OCT is never to be interpreted in isolation. You always need to have clinical relevance when you're interpreting the OCT. So having said that, we'll move on to the factors that the OCT scan actually has, which you need to take care of. So the ones which are patient dependent are media opacities and pupillary diameter. Operator dependent are centration, signal strength of the acquired image, and device dependent are acquisition speed, database related, and clinical paradigms of OCT scans. So the patient and disease dependent, if you have a pupil less than 2 millimeters, you could get an erroneous scan. Cataract could actually give a hazy media and also give an erroneous scan. Be careful your patient doesn't have dry eye, because that also can cause segmental defects in the OCT, and eye blinks in the tracking system can actually have missing data in the OCT. So the patient and disease dependent, well, if your patient has floaters, as you see out there, the areas of the floaters, you can actually mistake for anything as well as retinal nerve fiber layer defect. So you need to be careful that these are not floaters that has come into the way of your OCT. So blood vessels also affect the segmentation of the OCT. So when you're taking the OCT scan, if you're not taking it yourself and your operator is taking it, she needs to be aware of the vessels that don't come in the way. So poor signal strength leads to a faint image, and when we see this kind of an image, this is from the OptiView, you actually need to see this index, and if this is less than 50, then that could actually be repeated. So operator-dependent artifacts included truncation of the acquired spectral domain OCT image that you see out here. So the retinal nerve fiber layer was outside the acquisition of the image, and that's the reason you have this red pie that you see out there. And the same patient's RNFL scan repeated with the entire RNFL acquisition, you see that this is absolutely normal. Misinterpretation of artifacts. So localized losses of RNFL or macular thickness classified as normal due to averaging of the thickness values by quadrant or hemisphere. Misinterpretation of shadow artifacts, we just spoke about it. And we're just coming to the red and green disease. Now, what is red disease? Misinterpretation that occurs when a normative database is applied to a patient who should not be considered normal, as for example, a high myope. So in a high myope, the peripapillary area might not be the best that you want for the scan. And in these cases, basically, you need to be very cautious, or you could have an absolutely red pie diagram like this, looking abnormal, but actually it's not. And the green disease occurs in patients who have normal global values, such as average RNFL thickness, but have small focal defects. So a small focal defect actually might not be identified by the OCT. That's where you have the green disease. So red and green disease, high myopes and small focal defects, which can be missed by the OCT, and need for taking artifacts into consideration when you're interpreting the data from these equipments. So device-related artifacts, absence of eye tracking because of microsaccharides, not controlling of head tilt, absence of robust segmentation software in the OCT, and failure of recognizing of non-glaucomatous disease, such as we have the next speaker on the retinal changes in OCT, so I will skip that. And if you have a look at this, this is actually the relevance of the scans that we use. So we have this glaucoma premium module, which is there in the Spectralis, which actually has the benefit of all these 3 scans. I don't have any financial interest in the machine, but since it gives you all the 3 scans, you could actually do them and find out which would work out the best. The other machines actually give you the choice of just 1 scan. So that could be a little difficult. The other thing I would want to stress out here is the BMO central axis. So when you're mapping the BMO related, that is the Brooks membrane opening with the minimum ratio that is there, something like this, and you use the anatomical app of the Heidelberg, then once it maps the fovea in the center, related to that, it actually maps the BMO, that is the Brooks membrane opening. So each time that your patient comes, that particular section will be actually examined. So you are actually at the liberty of sitting back relaxed in your chair, that every time you see that patient, that particular segment will be mapped. So you have a absolutely standard follow-up. It's not that every time a different segment is mapped, which can happen with the other OCTs, but with this BMO MRW, minimum rim weight BMO. You can actually have this done with the APS scans of the Heidelberg. This is the spectralist glaucoma module of the premium edition, and this actually works to the benefit of the clinician. So that's a small thing that I got. This actually correlates even with the TISNET map, and misidentification of an artifact like the vitreoretinous interface can be misidentified. So I'll just move on, because these will be covered by my subsequent speakers. So what you need to consider are the operator-related factors and the clinicians, but the drawbacks which we have, I have also just gone through that. So these are just cases which I had, but in the interest of time, we'll miss all that. So are we actually in the middle of a paradigm shift? We actually could be, as long as these instruments are concerned. But one thing I would like to stress, that you definitely need to see all these instruments along with your clinical acumen. Do not base your diagnosis on any of these instruments without a clinical correlation. Thank you very much for your attention.